embolism. Some of our objectives are to review the epidemiology, to review the pathophysiology, to be able to quickly recognize amniotic fluid embolism in an obstetrical setting, review common complications, current treatments, and kind of what's coming about. So while we talk, I have a case that I want y'all to keep in mind, just to kind of get you in the mindset of this type of emergency and maybe make you a little bit nervous while we're going through. So there's a 35-year-old G4P2 with a history of 2 previous C-sections who was undergoing a repeat C-section. She was stable throughout surgery until delivery of the infant when she had a sudden loss of consciousness, became cyanotic with her blood pressure falling from 115/65 to 40/27, and a hemoglobin O2 sat of from 99 dropping to 88. So you want to start thinking about what your differential diagnosis would be, because you know the topic of the thing, so you know what it is, but it could be a lot of other things. So you could have an abruption, you could have anaphylaxis to something she was given in the surgery, she could have an aortic dissection, she could have aspiration, she could have a cholesterol embolism from surgery, she could have myocardial infarction, and she could have septic shock. And then, of course, she could also have the rarest thing on there, which is amniotic fluid embolism.
You have an air embolism too.
She could. So the true incidence of amniotic fluid embolism is kind of unknown because there's not a standard diagnostic criteria. They're all very similar, but they're not perfectly standardized across the world. So we're not really sure how many, but we approximate it to be 1 in 40,000. Some reports state as few as 1 in 600,000, and most of those are from Japan. So it takes up 5 to 15% of maternal deaths. It has a maternal mortality rate of 60 to 90%, and a perinatal mortality rate of somewhere between 7 and 44%. And then most of the survivors, 6 to 60% of them, have permanent neurological damage. So, does anybody know what this is?
Ebola?
Yes. You have a better chance of surviving Ebola than surviving an amniotic fluid embolism. The mortality rate for Ebola is 80%. You also have a same mortality rate as jumping off the Golden Gate Bridge, which is also a 90% mortality rate than surviving an amniotic fluid embolism. And a plane crashing into a mountain is only 50% mortality rate. So it's a pretty bad situation if you get one of these. Okay, so how do they present? So some of the things you need to look at are risk factors. So the ones over here on the side without the marks are pretty good evidence risk factors. The ones on the other side are reported in case reports, but they haven't been studied a whole lot. They're just kind of loose associations. Rapid labor, meconium is a big one. Uterine tears, if you get like a cervical tear or tear into the uterine artery during a C-section. Placental malimplantation, so if you have a creta or percreta, something like that, you have an increased chance. Trauma, abortions, I mentioned cervical lax. Amniocentesis, there's been some case reports of people developing them after amnio. And then manual removal of the placenta also can increase it. The loose associations are vacuum, forceps, abruption, AMA, post-term pregnancies, and C-section. There may be a maternal genetic mediated hypersensitivity to fetal antigens, which increases your likelihood also. It's more common in male fetuses than female fetuses, but survivors don't have subsequent episodes usually. So there are many different combinations of clinical manifestations. So you can have all of these things in any combination. And for the most part, they present in a specific way, and we'll go over that in a minute. But really, any of them can show up first. The most common, of course, that we hear about in all the case reports is cardiopulmonary arrest. That's usually where people actually notice that something's wrong, but you actually can have coagulopathy be your first sign also. It's not as common, but it can happen. So some of the pathophysiology. You have evidence of fetal debris in the pulmonary vessels. It's often found on autopsy, but it's not critical for diagnosis. And of course, you're not going to find it if the patient survives it, because you're not going to go take a piece. The incidence of embolism and toxicity increases with the volume infused and the amount of meconium. So they did some studies on dogs and monkeys where they actually injected human amniotic fluid with varying amounts of meconium in it. And in monkeys, it didn't really do a whole lot, but in dogs, it actually induced amniotic fluid embolism with the more amount infused and the higher amount of meconium. And there's 3 progressive phases of this illness, and they happen very, very quickly, so we don't really separate them out except in literature. So in phase 1, you'll have pulmonary hypertension. You'll notice an increase in the pressures. If you're in a C-section, the pressures needed for them to breathe, they start having difficulty. They have acute onset pulmonary hypertension, followed quickly by systemic hypertension. They have severe desaturation, and then it's very, very quick. The O2 desaturation follows the systemic hypertension secondary to poor perfusion of their lungs. And they have unrelenting pulmonary vasoconstriction. My mic went off. It didn't turn off. Can you hear me? I'll just speak up a little bit. Okay. I just turned it off and turned it back on. So you also have that pulmonary vasoconstriction leads to failure of transfer for the blood from the right to the left heart. And like I said, it's very quick. It lasts for minutes. And most of the time you find this if you happen to have somebody with a art line, or they talked about TEE, which is transesophageal echo. We don't really have those available in our OR at a moment's notice, but apparently somebody does. And so that's how they notice those. So this is just a little bit of a review of pulmonary hypertension. And it happens with, you get vasoconstriction, decreased nitrous oxide availability. You have desensitization to the vasodilation hormones that your body makes. You have venous congestion, and then you get inflammatory cells that release everywhere. And that causes right ventricular failure, which leads to passive transmission of left-sided filling pressures, and then you get a loss of compliance, mitral regurg, and then systolic dysfunction for the left ventricle. So phase 2 occurs if the patient survives phase 1. Most of them survive phase 1. And then hypotension develops, and that's secondary to decreased systemic vascular resistance, which also decreases your cardiac output. And then phase 3, if they survive phase 2, is when cardiovascular collapse happens. Pulmonary edema leads to ARDS, and then you can also get the consumptive coagulopathy, which is also known as DIC. And that's where we normally start picking it up more commonly. So on postmortem findings, you'll find fetal debris packed into the pulmonary vessels. You have to let the pathologist know what the clinical course was, because these require special staining, and so even though it's not required for diagnosis anymore, it's still good to know, and especially if you're looking for something that happened, this lady just, perfectly healthy lady just collapsed and died in the middle of a C-section, you probably want to find out why. And so you just let them know, and they'll do the special stainings. So these are some pictures. The bottom one is a gross picture of a pulmonary embolism from amniotic fluid embolism. And then the other one is a histological, and you can see the little layers of squamous cells kind of stuck in that artery. So a little bit about DIC. This is kind of a very simplified flow sheet of what happens. So you have uncontrolled thrombin generation, and you have decreased fibrinogen, which elevates your PT and your PTT, and it also chews up your platelets. So if you follow that one on the side, it chews up your platelets, and that causes diffuse bleeding. But at the same time, all your fibrin deposits are causing damage and hemolysis and tissue damage and multiple organ failure, and they're causing you're clotting and bleeding at the same time, basically. Eventually, you chew up enough fibrin that you get your vessels just kind of stop holding things in, and everything just kind of goes into third spacing, and then you get more diffuse bleeding. So you'll see patients with these big giant petechiae on them, and you'll have oozing from your IV sites, sometimes from their nose, sometimes from their eyes or gums, stuff like that. But the most common, because we all have an IV in everybody, there's like a spot you look. If they start oozing from their IV site, you need to get worried. So there's more at play than just fetal debris gets stuck in the pulmonary arteries. And you don't see mechanical obstruction in everybody. And so they think that there is an immunological factor to do with this that's almost kind of like anaphylaxis. Because the ARDS, the coagulopathy, and the neurosymptoms don't really happen in regular pulmonary embolism. It only happens in the amniotic fluid embolism. So they have a lot of studies on tryptase. Tryptase is a protease that is released by mast cells when they degranulate, and it's normally released with histamine. They have found in a couple studies that the tryptase levels were increased significantly, like 7 times above the normal limit. And it's thought to be because of the mast cell degranulation in the lungs. They actually have been kind of toying around with renaming it anaphylactoid syndrome of pregnancy instead of amniotic fluid embolism. I don't think that's really caught on yet. This does have a really poor sensitivity for amniotic fluid embolism because it can also come with anything that would make mast cells degranulate. So it doesn't necessarily mean that that's what they have. So there's also complement activation. Excuse me. They find that C3 and C4 are significantly depressed in these patients, especially survivors. There's poor sensitivity and specificity for both of those. So even though these are seen in the literature as being maybe something that's promising, we don't use them as diagnostic markers, and it's kind of research only right now. So how do you diagnose it? So it's considered a diagnosis of exclusion. It usually presents immediately after or during delivery. 70% of them present during labor, and then 11% after vaginal delivery and 19% after C-section. You need to recognize this quickly. Even though it's a diagnosis of exclusion, it should be in your brain. You don't have time to get a lot of lab work and figure out everything else. You kind of need to treat them like they have this too while you're trying to rule it out. Most maternal mortality is within 30 minutes. So there were some studies about changing the diagnostic criteria. Like I mentioned before, it's not completely standardized. It's standardized in our country, and it's standardized in Europe for themselves and in Japan for themselves, but not across the board. So they looked at, Clark et al. Published a study in October in AJOG, and that was looking at changing the diagnostic criteria for research studies so that they can get a better incidence. They came up with a consensus between the Society of Maternal Fetal Medicine and the Amniotic Fluid Embolism Foundation, and that, like I said, they were trying to make a uniform diagnostic criteria. So they came up with cardiovascular instability, respiratory distress, coagulopathy, coma, seizures, in the absence of other explanations. Japan, the difference between us and Japan and Europe is Japan has a time limit from birth. It's 12 hours from birth. So after 12 hours, you can have all this stuff and it's not an amniotic fluid embolism. The British don't have a time limit, but they include things like restlessness, numbness, agitation right before. Those are all part of their criteria. And then for our study here, and the consensus that they came up with was 48 hours from birth in the U.S. So some of the complications that can happen, and remember these all happen very quickly. For cardiovascular, you get hypotension. Cardiovascular collapse occurs in 80 to 90% of patients. You get pulmonary hypertension that leads to vasospasm, that leads to right ventricle failure, that leads to left ventricle failure, kind of like we talked about earlier. And it results in ventricular arrhythmias and cardiac arrest. Respiratory, you get acute pulmonary edema, and that develops into ARDS very quickly, and that's from the capillary leak due to the mast cell degranulation. So hematological, we talked about the coagulopathy and the DIC. You get intractable hemorrhage. A lot of times it occurs with uterine atony because it's around delivery, so they'll have uterine atony and DIC going on at the same time. And like I mentioned earlier, it could develop first. And then neurological is, these complications can be permanent in survivors, and so they can have altered mental status, agitation, seizures, encephalopathy. Like I mentioned before, most people who are survivors, 60% of them have neurological complications. So for fetal, like 70% are done while in labor, so the baby's still in there, so you're going to have a strip on them. So what you see with that is a loss of variability, then you get this terminal bradycardia because the body is shunning blood away from the uterus because the mother is dying, so it's shunning blood to the brain and the adrenals and all the stuff that happens in trauma and shock and all that. So here's some imaging. So if once you get a little further down the road, you can get some imaging. So this is an X-ray, and it just shows bilateral diffuse airway disease without any pleural fluid. So there's not like consolidation. It's just gray all the way across. There's no real pattern. A CT shows all the white stuff. There's supposed to be air there. It's supposed to be black. So this shows pulmonary edema. It's diffuse pulmonary edema, and that's due to having the pulmonary arteries backed up into the lungs. These are pictures of ARDS. As you can see, the x-rays kind of look similar because that's kind of what's developing, but the pattern on the chest x-ray is a little more almost granular, and you can see that other one was just kind of gray all the way across. You couldn't see what was going on. And so this you can kind of see that it's in the lungs and not surrounding the lungs. So how do we treat it? First thing, you want to have your patient on monitoring. So if they're in a C-section, they have most of this stuff. If they're in a vaginal delivery, they have a lot of this stuff, but like right after amniocentesis or something like that, they may not. So you want to get an EKG, you want to get a pulse ox, a blood pressure, and large bore IVs, as many as you can throw in fast. For labs, they suggest quickly getting labs and repeating them often. So more than you would normally, like every 4 hours, we'll repeat a pre-E labs on a patient we're worried about, or H&H on somebody who bled a lot. It'll be time down the road. They're talking like every hour, get them labs. So you get a CBC, BMP, mostly for the electrolytes. You want coags, which is PT, PTT, and fibrinogen. And you also want to get ABGs a lot because these people are developing neurological injury because they're not breathing. So you want to make sure that they're not going in, how bad their acidosis is. So most of the treatments we're going to talk about is just supportive treatments because that's really all there is. So you want to keep their oxygen sats up to greater than 90%. You want to have intubation, like we call anesthesia, or whoever your person is to intubate people, they need to be standing by because it's often required. Anesthesia can also give nitric oxide, which helps kind of dilate the pulmonary vessels a little bit. And then there's a couple of studies about some aerosolized prostacyclin, which can also be given by, I see all y'all looking at the screen, which can also be given by anesthesia, like during a C-section. Volume resuscitation is important, but you don't want to overload them with fluid. Their lungs are filling with fluid anyway, but you have to get blood back into their system. So you want to give them an adequate amount of volume resuscitation, but don't overdo it. And then cardiac support, because these people are going into heart failure. They're not maintaining their blood pressure. Their blood vessels are leaking. So you want to give them vasopressors, and you just want their blood pressure above 90. You don't want it to be crazy high. So when they develop DIC, the big thing we have a massive transfusion protocol here. And all you have to do is call the blood bank and say, activate the massive transfusion protocol. And they know what that means. Basically, it's O negative blood with FFP, platelets, cryo. All of that is a ratio of 1-to-1. So if you give one thing of RBCs, you're giving FFP, platelets, the whole thing all the time. And the reason that you're doing that is because FFP or platelets alone don't have enough fibrinogen, so you have to give all this stuff together to get that fibrinogen that you need that their body is chewing up. There is some data on recombinant factor 7A in postpartum hemorrhage. I know that's like one of the things after we get past a lot of our stuff we can call for recombinant factor A, and factor 7A. That's not recommended in this situation because, like I said, they're chewing up the other stuff. It's not the problem that's going on. So this study it was done by Tanka et al. And it's published in August 2016. It looked at the efficacy of transfusion with FFP and blood cell concentrate in the certain ratios. So we do a 1-to-1 ratio. This looked at a 1 or more ratio of FFP to blood cells. So they compared recommendations from Japan's JAOG is Japan's ACOG, and then our ACOG. We do the 1-to-1-to-1 with FFP, platelets, and blood cells, and they do FFP blood cells 1 or more. So they're giving more blood than FFP. And so it's a retrospective analysis of women with amniotic fluid embolism and coagulopathy. And it was broken into survival and death groups. And they found to have a higher transfusion rate of 1 or more in the survivor group. So 90% of people got it that way. So there's some evidence that you just flood them with blood products, and that tends to help. There were some confounding things in this study about patients who were recognized sooner or came in off the street with problems, who were in bigger hospitals, and they didn't really talk about those too much, but they were in the paper. So these treatments that are listed, these are all treatments that were discussed in different case reports. They're not necessarily recommended by anybody. There's not enough evidence to show anything, but these were all done in patients that survived. And so it's kind of maybe the future of where we can go if they get a little more data. So they do antithrombin concentrates, which I don't know if we have available here. We would have to check into that. Extracorporeal membrane oxygenation, but you have to be really careful with that because it can actually worsen bleeding. And so if they're bleeding profusely anyway, you probably want to avoid that. Intra-aortic balloon all their blood vessels were clamping down at the beginning, so you want to open them back up. Pulmonary artery thromboembolectomy, exchange transfusions. The only one that has a little bit of promise from more than one research paper is the high-dose corticosteroids. There's some theories that I talked about it as an immune-mediated response, and so there's some theories that the high-dose corticosteroids can help with that. It's given in combination with a bunch of other treatments, so there's not anybody that's going to only get steroids, so we don't really know if it's doing a lot or if it's just coincidental. And then there's a synthetic C1 esterase inhibitor. And then a while back, I always heard that when people go into DIC because they're clotting and they're bleeding at the same time, you need to give them heparin. That is not recommended. I don't know where that came from, but it was the thing going around here. We never had to use it, thank goodness. But just in case anybody else heard that as they were coming up, heparin is not recommended in amniotic fluid embolism. So if the baby is still in there, the delivery is indicated if they're greater than 23 weeks gestation. And that is emergent C-section delivery, not let's have a vaginal baby, she's 8 centimeters. It doesn't matter. C-section. You can consider a perimortem C-section if the patient has had cardiac arrest for more than 4 minutes. And then the most important thing that you need to do is somebody needs to start chest compressions while you figure out all this other stuff that you want to do, and you call for instruments and you call for all that stuff. Don't just stand there, do some ACS. Some life-saving. So the uterine atony that they're going to have if they're having a vaginal delivery or a C-section at the time this happens, a lot of times they have postpartum hemorrhage. We've always seen people that get thrown into DIC because they bleed too much during a postpartum hemorrhage. So you want to treat that kind of as normal. Start with your Pitocin and start with your Hemabate and Methergen. If you have to get down to all these things with Cytotec and a Bakri balloon, B-Lynch, do them while they're trying to figure out what's going on with the patient and trying to get that patient stable. Anesthesia, if you're in a C-section, can take care of the patient's airway and getting them intubated and all that. You don't need to be involved in that. You need to be stopping the bleeding that will be occurring. And if that leads to hysterectomy, so be it. So perinatal outcomes are actually inversely related from the time of cardiac arrest to delivery of the baby. So that 4-minute perimortem C-section rule is for the baby. It's also for the mom. It gets the pressure off the IVC so they can actually have some blood flow back to their lungs and brain, but most of it is for the babies to not be super acidotic. Survival rate for infants is actually 70%, but half of all survivors have neurological impairment and 28% had birth asphyxia, probably because of that 4-minute rule. So there is lots of novel treatments, like I mentioned that whole slide. Every new case report, every time somebody lives through this, they do a case report and they write what they did, and there's always some new thing that they did. So there needs to be a little bit more study into each one of those with more than an N of 1. An N of 1 doesn't really tell you a whole lot. And then there's starting to be a lot more studies about tryptase and complement markers. Those wouldn't be treatments right now, they would just be diagnostic. But it could help you diagnose it a little faster. It would take it away from being a diagnosis of exclusion. And then they're looking into other novel laboratory markers. Most of them are immune related. So it's different proteins on mast cells and different, some of the enzymes and proteases and stuff like that the mast cells drop when they degranulate. They're looking for markers of those to help separate it out also. And that is it. Any questions? No?